Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about an intubated patient who was brought to our ER after 12 hours of intubation with history of breathing difficulty and cough.
Okay, start.
Sir, initial assessment, patient was intubated and sedated. So coming to the primary survey, in the airway, the ET tube was present and there was no pooling of secretions as noted initially with C-spine appearing normal.
Okay.
The breathing, with the ventilator settings, the respiratory rate was 16 breaths per minute with the saturation of 98% maintained in 100% FiO2. And in circulation, his BP was 90/60 mmHg with pulse rate of 75 per minute and all peripheral pulses were palpable. Coming to the disability, GCS was even VTM1 with the pupils bilaterally reactive. In exposure wise, temperature was 97.5 degree Fahrenheit with GRBS of 225. So we went ahead with the.
Okay. So at this point, you haven't mentioned anything about the background of the patient. We have a patient, elderly gentleman, with a history of he's brought in with the on mechanical ventilator with a very high ventilatory settings with a normal hemodynamic status, right? Okay. Continue.
So went ahead with the adjunct to the primary survey. We tried to get a VBG, but initially it was not a. We only got a VBG, sir.
So you attempted an EBG but got a VBG.
VBG. So VBG, his pH was 7.35 with PCO2 of 52. PO2 of 36 with the saturation of 65 and bicarbonate of 28.3.
Okay.
So and also his lactate level was 2.1 with and his ventilator settings at, during the transportation was with the pressure of 16, PCV mode with pressure 16, PEEP 12 with respiratory rate of 16 and IE ratio of 2.2:1.
Okay. Reverse IE ratio.
Reverse IE ratio.
Okay.
And he was achieving a tidal volume of 550 with FiO2 of 100%.
Okay. Fine.
So we went ahead with the further.
So at least in this is one situation where we will definitely need a arterial blood gas to make any decisions. But fair enough, you have got a VBG which doesn't show a major metabolic issue, right? Okay.
So coming to the further history, as such he was no known comorbidities, but he was a alcoholic patient.
Okay.
Daily intake of alcohol was there, and he is a 57-year-old male who was having a history of high grade fever with chills and rigor and breathing difficulty for the past 1 week.
Okay.
With the cough for the past 1 week, and breathing difficulty was progressive. Not as such initially he was not having breathing difficulty. Over the last 1 day he was having progressive breathing difficulty.
Okay.
For the same, he had history of taking antibiotic amoxicillin 5 days for the last 5 days, and as his symptoms got worsened, in the same day of intubation morning he went to the local hospital where he was intubated with the we don't know the actual history, with the history of like respiratory distress as from the bystanders they were saying, with decreased saturation of 45.
So on arrival he was found like that.
They were
to the outside hospital. Okay. Any history of vomiting, risk of aspiration? The sensorium was fine.
Sensorium was bystanders were telling the sensorium was fine with no history of any vomiting.
Okay. Okay. Correct.
So further we went ahead with the further evaluation including a chest X-ray. Chest X-ray was showing bilateral diffuse non-homogeneous opacity, sir.
Okay. So let's wait here. So basically we have an elderly gentleman with no other significant comorbidities but ethanolic, 1 week history of fever, probably some kind of an infection was brewing, and then sudden onset breathing difficulty. With that history is going there, and since in view of hypoxemia and tachypnea, he was intubated. That's what you're saying. Okay.
Then we also took a ECG. ECG was showing a normal sinus rhythm with a heart rate of 78 per minute. And also we did an echo. Echo was showing a good LB. Screening echo was.
Okay.
So we sent ahead with the routine blood investigations also, sir. Routine investigations noted to have a total count of 6,200 with platelet count of 1,50,000 and HB of 15. And CRP was 72 with procalcitonin, which we got later of 0.4. And we also sent pro-BNP, which was 2098. And TROP-T was 0.07.
Okay. Fine. Then what's your working diagnosis at this point?
So working diagnosis, the patient had a history of fever with cough for the last 1 week, and like last 1 day he was having breathing difficulty. So can be a fever followed by LRT and pneumonia, or else sudden onset of breathing difficulty can be attributed to a cardiogenic pulmonary edema, or else if we also send the creatinine values as creatinine values were normal 1. So chance of nephrogenic pulmonary edema has been ruled out. So other things are aspiration can be cause for the breathing difficulty, or else any vasculitis induced.
Okay, so definitely from the labs there are certain indications that, and history of fever and everything was there, and inflammatory markers were also high, but with a negative procalcitonin, right? So we will more like bet on an infective etiology leading to a respiratory worsening followed by and severe hypoxemia requiring ventilation. But there are few signs which are probably indicating of a associated cardiac involvement also. Okay, as evidenced by BNP, but echo is not showing anything, no underlying cardiac issues in the past. Okay, so what next?
So the further management was to as the patient was having in ventilator with a high FiO2. So
what is the saturation on arrival?
Saturation 98% in FiO2 100%.
Okay, fine.
So we had to reduce the saturations, reduce the FiO2 of the patient, but and also his ventilator settings was during travel time inverse ratio, IE ratio was also there. So we started the patient on ventilator settings with for the reduction of FiO2 and to continue achieving a tidal volume like we are setting a tidal volume of 6 ml per kg. So above 400 we try to achieve.
Okay. So what's your diagnosis at this point? What are you thinking about to make such changes in ventilatory strategies?
So the main differential diagnosis from the differential diagnosis we arrived at a initial diagnosis of ARDS.
Okay.
As such, because the echo was normal and also patient is having a history of 1 week onset of breathing difficulty with not cardiogenic causes which were ruled out, nephrogenic causes ruled out, and also X-ray was showing bilateral opacities with the patient is having a PaO2 by FiO2 ratio of mild.
Okay, so you are saying this could be ARDS, reasonable rule out of cardiac component assay. So what are the common causes of ARDS?
So mostly the ARDS can be attributed to sepsis or bilateral pneumonia.
Okay, so that is two different entities. No, one is a primary lung issue, that is a pneumonia, which could be of any etiology, viral, bacterial, or any other microbial etiology, which in fact leads on to ARDS. Usually it happens within 1 to 3 days of the inciting event, is what usually we say. Okay, that is one track. Second thing is a systemic issue, right? Like an sepsis. Any other focus of infection leading to sepsis as part of a global involvement of multi-organ dysfunction, you get ARDS also. So that is a second line. So next is?
Then non-infective causes we have to check, sir,
like?
Which include like pancreatitis,
okay,
then vasculitis, then eosinophilic granuloma, with then shock induced or transfusion induced, burns, trauma. Then stem cell transplant and drugs toxicity like amiodarone drug.
Okay, so basically you have it's a non-cardiogenic pulmonary edema will be the broad kind of thing where we have told all these causes. Fine. So that is with the cause. So here in this patient specifically, we feel it is more of an infective etiology which is leading to it, right? So the patient is already intubated by the time you reached here. So what are the things which you can do to kind of confirm your thought process at this point?
So
what is the diagnostic criteria?
Diagnostic criteria is the Berlin's criteria, which got updated recently.
Okay.
So the Berlin's criteria with the new updations, the criteria.
That's the 2024 update,
2024 update. So we had to have the acute onset of insult within 1 week of the
inciting event.
Inciting event. Then the PA2 by FiO2 ratio should be less than 300. Or
you're talking about mild.
Mild, sir.
Okay.
Or else, in case of non-intubated patients, according to the new ARDS criteria, the SpO2 by FiO2 ratio should be less than 315.
Okay, 1.5.
So that is mild. And in cases of moderate, mild, it should be less than 235. And in moderate, it should be less than 148. That is the non-intubated patients who are in CPAP or HFNC.
Okay.
So other thing is that the X-ray or CT.
Again in CPAP, it is, I think the pressure is around 5 and the flow rate for HFNC is 30 liters.
And then X-ray or CT showing bilateral opacities and atelectasis. Or else the new change addition which is added to the criteria is the ultrasound guidance where B lines can be seen in B lines which are seen in.
So can you be more specific at that point?
So B line should be.
So basically, in a single ultrasonological field, there should be more than 3 B lines with an inciting pleural pathology.
There is no cardiac or renal event.
Okay.
Then other things that we should be thinking about the risk factors for the same, like pneumonia or non-pulmonary infections, trauma, transfusion, aspiration.
What we have told, yeah.
Then we had to look for there is no evidence of any left atrial hypertension.
Okay.
These are the new criteria in the Berlin's criteria.
Okay. And other laboratory investigations will depend upon the inciting etiology which you are suspecting, right? So if you are suspecting a septic kind of an etiology, whatever other laboratory investigations which will support a septic cause needs to be worked on. Right. So then you moved on with the X-ray, right? So X-ray, what are the usual findings?
X-ray will be showing bilateral diffuse alveolar opacities with the dependent atelectasis.
That is the key thing. Okay. So usually your pattern of involvement will be more on the
both sides.
dependent areas. The predominant findings is going to be on the dependent areas. Fine. Then
X-ray will be also showing, CT will be also showing the same kind of findings. And
okay.
Then so we
can come back to our patient.
So we changed the ventilatory settings initially, sir. So we try to reduce the FiO2 and also to achieve a tidal volume. Low tidal volume settings for ARDS, no tidal volume ventilation. So for low tidal volume ventilation, we'll first initially we had to get the weight of the patient.
Okay.
So weight of the patient can be calculated according to the height of the patient. So from the height we had to calculate 50 plus 2.3 into initial height minus 60 inches. We'll get the weight of the patient.
Okay.
From the weight into so we'll set a tidal volume of 6 ml initially. We'll get the actual tidal volume.
Okay. So basically this was based upon the ARMA trial or the ARDS net trial, where you compared two limbs, that is one group with a 4 to 6 ml per kg of tidal volume and other with around 12 ml per kg of tidal volume, where there was a mortality benefit which was found in the low tidal volume group. It is after that we went ahead with the low tidal volume group. So that is with the tidal volume. How will you decide on the PEEP?
So PEEP can be decided by the driving pressure, sir.
Okay.
Driving pressure is the pressure that PEEP plateau pressure minus the PEEP. So driving pressure less than 15 is desirable for us. So we can initially if target a high increased PEEP to get a driving pressure less than 15, sir.
Okay, but do you think high PEEP is always needed in ARDS?
No, sir.
No. So basically there are two types. Okay, broadly you can classify it into two phenotypes based upon the PEEP responsive and PEEP non-responsive ARDS. So your use of PEEP is going to come into play only in the PEEP responsive subgroup of ARDS. And there are various methods in which you can regulate the PEEP. If you go by records, there are more than 12 methods to decide what is the PEEP. The new term is more of like an optimal PEEP or a personalized PEEP per patient. So one of the common method which we can use is regulate the PEEP as per the lung compliance. Okay, so you start with a PEEP, you increase it by increments of 2 until a point where you reach a good compliance. So say you are going on increasing, you reach a PEEP of around 12, you reach a PEEP of around 14 and your lung compliance is at a specific level. So once you go into 16, your lung compliance again starts to come down. So the point at which you are going to get a good lung compliance might be an optimal PEEP for that patient. So that is one of the easiest methods now to identify the optimal PEEP for a specific patient who is responding to PEEP. So how will you identify a PEEP responsive patient? So you keep the patient on a higher PEEP, you repeat a blood gas if there is an incremental increase of at least 25 of PaO2. So your PaO2 was 90. You keep the patient on an increased PEEP for the next specific period of time and you recheck an ABG, there is an increase of at least 25 in PaO2. That group of patients probably will fall into a PEEP responsive patient and you can go by the optimal PEEP as per lung compliance. There are other methods also, like ever heard about lung impedance tomography? So lung impedance tomography is where you place specific leads over the chest and you get a schematic representation of the lung aeration. Okay, along with that, by adjusting the PEEP, you can see which all areas of the lung are getting adequately ventilated. Okay, then there is esophageal manometry. So wherein you place a separate kind of a catheter into the esophagus and along with the esophageal changing pressures, we can again titrate the PEEP. So there are various methods. One of the easiest method which we can always follow is adjust the PEEP as per the response to compliance. Okay, so remember the keyword of optimal PEEP or a personalized PEEP per patient. Okay, fine. So that is with the PEEP then.
So the ventilator settings. So we had to have a
By the way, I told about compliance. You know, how do you calculate the compliance? Okay, so most of the newer ventilators, you will get compliance in the ventilator itself. You see and you, if at all you are not getting a compliance, usually the compliance formula is compliance is equal to tidal volume divided by plateau pressure minus PEEP. Okay, fine. Then.
And so low tidal volume, then further management like permissive hypercapnia can be tried for the patients. Then
so how low or the pH can be in permissive hypercapnia?
pH less than 7.35.
Okay. You can accept a pH of as low as 7.2 with a PCO2 of around 55 to 60. So that is the level of hypercapnia which can be accepted. Why are we accepting hypercapnia? Because you are trying to increase the oxygenation at the expense of carbon dioxide. So there also you were talking about the inverse ratio, and also if you are going upon the coming down on the expiration, naturally your PCO2 is going to go up. So our aim is not to induce hypercapnia. Our aim is to increase the oxygenation at the expense of carbon dioxide. Okay.
And prone ventilation is the next method.
So we will just finish off the proper normal ventilation. So one strategy is, you talked about the PEEP. Other thing is FiO2. FiO2 also probably our aim is not to decrease the FiO2. Our aim is to achieve a specific target PaO2 or SpO2. So at times you might end up with 100% FiO2. In spite of that, the patient's saturation may not improve, right? So it was in the ARDS net criteria where they ended with the FiO2. That is a high FiO2 low PEEP protocol, and the high PEEP low FiO2 protocol, where what happens once you attain the target goals, you either start decreasing the FiO2 or decreasing the PEEP. Got it, right? So that is in a situation where the patient is responding. At this point, we have moved on from that. We have moved on to the optimal PEEP, where you try to maintain the optimal PEEP and titrate the FiO2 on the other end. Right? Okay. So that is with this. Mode of ventilation?
Mode of ventilation, we can either choose volume control or pressure control.
Okay.
So we went ahead with the pressure control, so that we could have a pressure that can be set accordingly.
Okay.
When we are going ahead with the volume control, the thing is that pressure can vary, and which can cause barotrauma.
Okay. Both has its own plus or minuses, and there is no strong evidence to say that one is better than the other. So it depends upon that. At the end of the day, the user's preference. You can go either with volume control or pressure control. Okay.
So
there are advocates for both. Okay.
So plateau pressure should be less than 30 with respiratory rate less than 35, and also had to have a low tidal volume ventilation, 6 as an average, with the PO2 maintaining of 55 to 80 and saturation of 88 to 95%.
Okay, fine. And okay. And you told about the inverse ratio also. So if your oxygenation is not improving, one thing is you are going up on your PEEP, you are going up on your FiO2, you are going to, if both are not improving, you are going to play around with your IE ratio. IE ratio titration as per your acceptable hypercapnia. Okay, fine.
Then other things we can do.
Before proning, again, one more thing will be to minimize the dysynchrony. So there is something called as dysynchrony index. Okay, so dysynchrony index is basically your in one respiratory cycle, not in one respiratory cycle, in a minute how many respiration is there, in that respiration how many asynchrony was there. So say you set the respiratory rate at 12 and you have a event of dysynchrony of 2. So basically your dysynchrony index should be less than 10. Okay, so if your dysynchrony index is high, that again says that there is something you need to control. Maybe it could depend upon the various phases of thing. It could be a flow dysynchrony, it could be a trigger related dysynchrony. Okay, so you have to correct that. And probably one of the measures might be to paralyze the patient also. Okay, so always once the patient is on ventilator, think about all these things. Okay, then only you are going to think about proning and all. So you have to optimize the ventilatory measures on a patient before you go into proning. So you do all these things. In spite of that, you are not able to maintain a good oxygenation is where you are going to consider about proning. Okay, tell.
So further we can go ahead with
now you have a patient whom you are maximized your ventilatory strategies. In spite of that, you are maintaining a lower PaO2, then you are going to consider about proning. So what is proning?
So proning is the method by which patient from the supine position, patient is position is changed to prone position.
Good.
Because that as such the posterior part of the lung has more area, surface area, which will help in increasing the blood oxygen exchange. As patient is having a gravity dependent collection of fluids, which will get change in position will help in increase oxygenation.
Okay, fine.
The other things.
How long will you usually prone? So basically at this point you are going to completely sedate the patient and keep the patient on the downward direction. Okay, and how long will you usually prone?
Proning is dependent upon whether the patient is having a hemodynamic stability or not. If the patient is hemodynamically stable, the normal average time for proning is 16 hours.
Okay.
And following which we will again change the patient, deprone the patient, and if needed we will again.
Okay, so usually the studies have been on 12 to 16 hours. Okay, one session of proning is technically used to be 12 to 16 hours, after which you kind of deprone the patient and reassess. But there are enough newer papers coming up that you can go for a prolonged period of proning. If the patient is responding well to proning in the initial 12 to 16 hours, probably for 24 hours, and even up to 36 hours proning has been tried with good response. Okay, so you get response with a single session of proning, probably you will consider for one more session of proning also, right? Okay,
then the other things that contraindications for proning are if the patient is having a hemodynamic instability, or patient is having any facial abnormalities, facial changes, or if patient is having any spinal surgery done or any abdominal surgery done.
Okay.
That's included
with the proning. So that
the next thing we can do is if needed we can have an alveolar recruitment, sir, like increasing the PEEP. Or open lung strategy.
Okay.
The next thing is like if at all the patient is not improving with the recruitment or the prone position, we can always try with ECMO also, sir. And initially, as I told, sedation is an important part of the process. If sedation is not there, patient can have dyssynchrony also.
Okay. So here again, you have told about proning. If suppose the patient is not improving in proning, is when you are going to consider for ECMO. ECMO again, I mean, we'll leave that for a detailed discussion later. But the usual thing will be if the what point of your conventional management are you going to consider ECMO? So basically, you have a patient whom you have optimized all these measures. Your optimal PEEP, you have prawned the patient, you have used all pharmacological measures also possible, and you have on the maximum ventilator strategy, you are not able to achieve a PaO2 of more than 50 for 3 hours. Or if you are not able to achieve a PaO2 of more than 80 for 6 hours. Right? These are the probable indications where you are going to consider for a ECMO, and especially in ARDS, all you need is a venous ECMO, where your aim is just at the oxygenation and ventilation component of it. If the patient is having a hemodynamic compromise also, where the cardiac involvement is also there, then probably even in ARDS kind of situation with the cardiac involvement, we will go for a veno-arterial ECMO. So that is again a completely different kind of a story. So any other salvage therapy before ECMO and all? Salvage kind of thing, experimental or certain other things which you can try other than this in ARDS? Steroid, what's the role of steroid?
Steroid can be given in some conditions, sir. Steroid can be given in ARDS patients with septic shock,
Okay.
or else if patient is having a steroid responsive ARDS like eosinophilic syndrome, or else in patients with COVID or community acquired pneumonia.
So there is again a subgroup of patients where steroids can be tried. What about nitric oxide?
Nitric oxide and prostacyclin can be given as vasodilators, which can improve in resistant cases of severe
So definitely
cases.
you are justified in trying NO and all before going for an ECMO. Okay, fine. Anything else?
Then the extubation of the patient, sir.
Okay.
So if extubation of the patient can be done if the patient is maintaining an FiO2 less than 40 with PEEP of less than 8.
Okay.
And after patient is been removed of the sedation, if the patient is able to move limbs, we can further go ahead with the extubation plan, sir.
Okay, fine. Okay, right. Anybody wants to add anything? Okay, right. Thank you.